be picking up sounds, and that means that you'll get present OEs, but it's not sending those signals properly to the brain. So you do the ABR to check the functioning of the acoustic nerve, and then you can decide. If the ABR is normal, or if the ABR correlates with the audiometry results, then your audiometry is most probably like it's a sensory neural hearing loss. But if the ABR is abnormal and it does not correlate with the audiometry results, and the OEs are present, that means you might have a neural hearing loss. So there's something wrong with the nerve fibers themselves. Yeah. Yes. Okay. So that's what we do. We have many patients like this, and their ages are typically between 20 and 30, or like 18 and 30. We don't know why exactly it's happening. There are theories that it's either nutritional or environmental causes, but we've seen a lot of young adults with this issue, and they come in, they might have a mild hearing loss, they might have a severe hearing loss, OEs are present, and you do the ABR, it's abnormal. So it's auditory neuropathy. There's not so much literature on this syndrome specifically, but it seems to be some sort of polyneuropathy, because these patients typically also have issues with their vision. Yeah. So that's what we would do in that case. We would do the ABR, and then hearing aids help sometimes they don't help. Yeah. So sometimes you'll fit them with hearing aids and it still works. And the issue is that we think that they have a problem hearing, but this ear is picking up sounds. It's not translating them well along the nerve. So when you put hearing aids on, they increase the level of sound, but they will not help with translation of those sounds to the yes. Yeah. In these cases, we have not tried cochlear implantation in these adults, but I don't know if it would benefit much. So we don't actually have a recommended management procedure for them. Some places use neural support, like vitamin B, for a prolonged time to see if that makes a difference. Some of them benefit with hearing aids. There's a variety of different management styles, but it's not really something that we don't have a solution for them, unfortunately. Yeah. Okay. Any other questions?
And how about this thing of speech audiometry here in Tanzania?
Speech audiometry. Yeah, we do.
List, yeah?
We don't do speech audiometry. We don't do speech audiometry. Do I recommend? Is it something that you can do? Yes. Is it something that I recommend doing in clinic? Not so much. Not for us. We can create a word list and we can do it. Yeah, we can create a word list and do it. But at this moment, it's not something that I'm looking into. Yeah. Okay. Yeah. But that we can discuss later on about the word list and about why I think that we should stick to other means of measurement first. Okay? Alright, so now we'll talk about the ABR. Okay? So it's an electrophysiological test of the auditory brainstem response. It's not a hearing test. It's a test of the nerve impulses or the action potential generated along the acoustic pathway. Okay? From the cochlea all the way up to the MGB on the way to the auditory cortex. So these are the centers that we're looking at. We have the cochlea, and we'll have the cochlear nerve here. Then we have the cochlear nucleus, the superior olivary, inferior colliculus, and the medial geniculate body. That's what we're testing on the ABR pathway. And we'll see where the waves come from as we're testing. Okay? It is an objective measurement. So when we measure it, if all the conditions are met properly, if the patient is prepared properly, it is objective, because the patient is not responding to you. The patient is not giving you any sort of response or anything like that. But reading the test is subjective. It's the same thing like in radiology. The MRI is objective, but the radiologist's report, one might report differently to the other one. So it's the same thing. The audiologist needs to know, and it actually has to be a collaboration between audiologists. Sometimes you'll get results that are very clear. Sometimes you'll get results that are not so clear, and you need 2 or 3 people to look at it and see if you're seeing the same thing. Okay? Now, what applications do we have for ABR? So the first thing is any patients who you cannot do audiometry for. So if you have newborns, if you have infants, if you have people with special needs, people who have communication issues, you can do that. You use the ABR to threshold. You use it for non-organic hearing loss. So in compensation cases and in malingering patients, often the ABR is the gold standard. That if a patient comes in, if the company or their employer suspects that maybe they're making up their hearing loss, or they're pretending to have a hearing loss, the OEs are not the gold standard. You need to do an ABR to prove that they can hear. Okay? In newborn screening, of course, as we said, and then retrocochlear pathology and intraoperative monitoring of auditory nerve function. We have not used this application in Tanzania, as far as I'm aware, but you can use it in cases where you have resection of vestibular schwannomas, or you have resection of nerve of lesions that are very close to the internal auditory canal, to make sure that you're not harming the cochlear nerve intraoperatively. Okay. Now, when we look at the anatomy of the ABR and the waveforms, so these here are the 7 waves that you will typically see when you're performing the ABR. Okay. You have wave 1, which is very early there, and then you have wave 7, which is at the end there. The 3 peaks that we normally look for are 1, 3, and 5. And 5 is the most prominent. So even if you don't see all the other ones, if you see 5, that's a response. Okay, you don't have to look for the others. Now, where do they come from? So sounds go through the outer ear, they go through the middle ear, and they enter the cochlea, and then they travel up the cochlear nerve. Okay, when they go up the cochlear nerve, the first wave, the very first wave, comes from the lateral portion of the cochlear nerve. So just as it exits the cochlea, that first wave is generated. It's an action potential that is generated just as that nerve is exiting, as that signal is exiting the cochlea. Then you have another waveform that comes from the medial end. So from the medial end, as it's entering the brainstem, you will get another action potential, or another reading that we can see over there. So we have the distal end and the medial end, or proximal end. And then as the signals reach the cochlear nuclei, you will get wave 3. Now all these nerve signals come together into the cochlear nuclei, which is why it generates a bigger wave than the other 2. Okay, so as it's entering the brainstem now. From there, these signals and these nerves travel to the olivary nuclei, which you can see here is very close to the 5th nucleus. The 5th nucleus is the most prominent one. So you can see it's the most prominent one. It's the one that we use to give us a response. If we don't see the 5th one, we generally don't mark that as a response. Okay? So you have to find wave 5. When you're reading, when you're looking for anything, it's wave 5 that we look for. And the wave 5 is generated at the lateral lemniscus. Now the lateral lemniscus, there's a reason that it produces the largest and most robust waves. The lateral lemniscus is like a bridge. Or it's like, you know, when you come to the port, there's that scanner. There's one scanner, but there's like 5 ferries. So all those ferries come in, and all those people are going through one scanner. And the reason that it generates the biggest is because you have all of these signals that are coming in, and they're going through a single tract. So it generates the biggest response, okay? Because you're taking a lot of roads and you're feeding them into one gate. And then after that, we don't really look at 6 or 7 because those are higher brainstem centers. There are other tests, electrophysiological tests that you can do. You can do middle latency responses, you can do cortical evoked auditory responses, but we don't perform them here. Okay? So those are later centers of hearing.
No.
Yes.
Where is the interpretation taking place?
Where is the interpretation?
Yes.
Of
wording. Because, like, the wave 5 is in the
Yeah, here.
that
And
unlimited.
discuss.
Yeah.
Yes, that is where the interpretation is happening, because like
Oh, where the
getting
interpretation
sound
of
and
sound.
understanding the,
Okay.
the speech is two different things, right?
So the interpretation is actually happening in the cortex, auditory cortex in the temporal lobe.
Mhm.
Okay.
Yes.
What this is doing so far, so in the cochlea, as these sounds are exiting, there's a lot of coding that happens along this pathway.
Right.
So first of all, in the cochlea itself, there's a lot of place coding. Different nerves or different hair cells are excited by different frequencies. So we know there's different frequencies that are excited, whether you're at the apex, which is high frequencies, and the base, which is low frequencies. And those then send the signals to the nerves. Now the nerves are also place coded. So as the acoustic nerve comes, it's actually a bundle. It's not one nerve. So when those bundles come in through this center, they're all place coded. And in the cortex, it's also place coded. So when these signals reach the auditory cortex, they actually have different areas for different frequencies. So they carry that place coding from the cochlea all the way up. Now, when you go into these areas, and when you go into the cochlear nuclei, when you go into the olivary nuclei, there's a couple of other things that are added. So you have, first of all, time coding. And time coding is it's the phase coding of those auditory signals. So what was the timing of those auditory signals? How did those sounds come in, and how were their phases as they came in? And it's actually more physics than biology, if you look at the whole ear and the whole hearing system. But there's a lot of phase and time coding. And then the other thing that you get is this here is a unilateral connection. But following on from here, there's a bilateral addition as well. So signals come in from the contralateral ear to these nuclei. And then you get things like interaural intensity differences, interaural time differences, and you get some unification of the signals that are coming in as well. So there's really a lot of processing that's happening in these centers before it gets to the auditory cortex, where the sounds are processed. Yeah, and the sounds are then interpreted. Yeah. But all of this so far, what it does is it takes the information from here and from here and just puts it in nice little packages. When it gets to the auditory cortex is when those packages are opened and we start to understand what is being said. Okay?
Yeah, but then, this is not, it's not, what should I say? Getting a positive V5
Yes.
does not mean that the kid will be able to speak.
Does not mean that the cortex, the cortical function
will be able to interpret.
is perfect. Yes. So there might be other issues. There might be other issues with cortical interpretation. There might be cases with CP, for example, where you might have perfect normal hearing, normal brainstem response, but it's the cortex that has an issue. We've seen. So it does not mean that this is just the signal. It's just the microphone. The microphone and the wire is working fine, but if the computer is not working, it's not going to do anything. So yeah, There
are other tests that you can test
Beyond.
Yes,
Beyond, yes. So there are cases where you might need to do cortical responses to check the cortex's interpretation of speech sounds. In those cases, we don't even use click or chirp stimuli. We use speech sounds to see if those complex speech sounds are being picked up and understood by the cortex. But it's very, very rarely performed. Very rarely. Okay. Now, when it comes to interpreting results, there's a few things that we look at. So the first thing that we look at is the wave latencies. Are the waves in the right place? Okay. You will never get a wave 5 that is over here. It doesn't happen. Okay. So you have to make sure that according to time, they're in the right place. The second thing is inter-peak latencies. So you have to look at the latencies or the time difference between the peaks as well. Is the difference between wave 3 and wave 5 normal, or is it extra long? If it's prolonged, there could be something in the way that's causing that prolonged latency of the latter wave. And then the morphology. ABR waves generally look the same. For patients, if you do it for patients, 3, 4, 100, 200 patients, they all follow a certain waveform. So ABR waves will not be so different patient to patient. Yes, there might be noise, there might be other factors, but that wave 5, the general morphology of the wave is the same. Okay? And the other thing is replicability. You cannot just do one ABR trace and say that this patient is normal. You have to do it 2 or 3 times to make sure that yes, this is an actual response. The same way we do audiometry. We check each frequency 2 times, and with ABRs we have to check. Okay? Now, this is an example of a normal ABR. So, you have wave 1, you have wave 3, you have wave 5. You can see 6 and 7 as well. You can't see 4, you can't see 2. But the main one that we're looking for is 5. Okay? If you get the others, it's a bonus. You check that they're along the time. So, wave 5 at 75 dB should be around 5 to 6 milliseconds. Some software shows you, some just lets you interpret. And then you look at the interpeak latencies as well. So the difference between waves. Now if wave 1 and 3 were close together and then 5 was somewhere here, you might feel like there's something between wave 3 and 5. Okay? Or if 1 is here and then 3 is all the way over here and then there's 5, again, it might tell you that there's something on the nerve that's causing that prolonged latency. Okay? And the other thing is you look at the other side. So are they similar? If you have to look at the 2 sides and see whether they're similar or not, and to see if you see the same pattern within the 2 sides. You also repeat the traces. So this one at 40 has been repeated. You can see wave 5 here, you can see wave 5 there. So there's good repetition of the waveforms. Okay? So this is what I'm talking about when I talk about replicability. You have to make sure that you can repeat the tests and the test will look the same. Okay? When you do it at 90, 80, 70, you don't have to repeat it at every frequency. But especially at threshold, when you come to 30 or 40, you have to make sure you repeat it so that you see that response at least twice. Now, as intensity decreases, so you can see up here, you can see wave 1, 3, and 5. But down here, you can really only see 5. And that's why I say, just if you keep looking for wave 5, that's how you perform the ABR, that's how you interpret the ABR. Okay? 1, 3, and 5 you will see most of the times at higher intensities. Lower intensities, you'll only see 5, but yeah, just keep looking for 5. The other thing that you do when you're interpreting the test that you have to do is the left and right comparison. This is something that we're used to doing. When we do otoscopy, we have to check the left and then the right. We have to check both sides. When we do tympanometry, we have to test both sides, whether you have a problem on one side or not. Audiometry, same thing. And ABR is the same thing. You have to check the 2 sides to see if they're in line with each other. This is a normal hearing case. So you just put the left side on top of the right side and you check whether they're similar. If they're not similar, you might have an asymmetry, you might have some other issue with one of the sides, but you have to check the symmetry of the sides. Okay? And if you have differences between the latencies, let's say wave 5 for red is here and then the blue one is all the way over here, you might have a unilateral hearing loss. You might have not put the insert or the headphone correctly. So I've seen cases where one side is showing a severe hearing loss, one side is showing a normal hearing, and then you just put the insert or the headphone correctly and then you get normal peaks. It happens. And then you could have a conductive pathology. So you might have otitis media, you might have some earwax, you might have something else that's obstructing the ear canal or the middle ear that's causing a conductive pathology and therefore a difference between the sides.
Just come back.
Yeah.
Which means you will never get big difference between when you are doing ABR on the right and left.
you should not get a big difference. If it's a normal case with no other issues, you should not get a big difference. You should get it like this, laying more on top. So if there is a difference, it's usually due to these three reasons. And of course, the placement of the electrodes and things like that as well. But if you control for that, then you should not get a very big result.
What is the reason? Because we could have unilateral
Yes.
hearing loss.
So if you have a unilateral hearing loss or asymmetrical hearing loss, you will get a difference. If you get a conductive pathology on one side, you will have a difference. And if you have placed something improperly, so if the electrode is not placed properly, if the headphone's not working or it's not placed properly, the insert's not placed properly, you will get a difference. Okay? So in a case like maybe if there's a conductive pathology, then you would check the ear, you would do a tympanometry to see what else there is. You might do a CT scan, it depends. You could also have a difference because of retrocochlear pathology. So if there's an acoustic neuroma or something like that, you might get a difference between the right and left side. But that again is an effect of the asymmetric hearing loss. Okay? Any questions up to now? No? Okay. So what factors are there influencing the ABR? What do we have to keep in mind when we're performing the ABR or when we've scheduled a patient for ABR? Okay? So age is the first thing. When you have newborns or you have premature babies, you might not get the peaks that you're used to seeing. You might see the peaks are very prolonged. Okay? They might be very late. That's normal because as time goes on, those peaks normalize. We have age controls normally so we have normatives according to age. So if you check the ABR normatives, for newborns, it'll be different from a child who's 3 years old or 4 years old. Okay? If you have some child who's premature, sometimes you will only see wave 1 or wave 3. You might not see a very prominent wave 5. That's okay, it's normal. Again, you just record the test and you repeat it at a later date to see if that maturation has taken place of the auditory system. Gender doesn't really have a significant difference. It doesn't have an influence. Wave 5, they say that might have more amplitude in males than females, but generally, you shouldn't have a problem finding them. Body temperature is important. So in colder rooms, you might have slightly longer latencies than in warmer rooms. That doesn't mean that something's wrong. It's just that there's a slightly lower body temperature, which is causing a bit of a prolonged latency. Again, it doesn't really make a difference. The other thing is muscle activity, which is the most important one. If the patient is awake, if the patient is moving their eyes, moving their head, they're restless, that will make the waveform, look different, and it might even hide the peaks or hide the responses. So you will have your ABR will be influenced negatively if the patient is not relaxed compared to when the patient is relaxed or sleeping. Now, when we look at stimulus type will also change your waveform. So are you using clicks? Are you using tone bursts? Are you using chirp? Which ones are you using? We have different protocols for different stimuli. Some places use click stimuli. Clicks are the old ones, and they're the ones that are used by a lot of platforms. They typically have a center frequency of around 2 to 4 kilohertz. So their information is mostly elicited from that area. Then you have tone bursts, which can be used to measure 500, 1K, 2K, and 4K. And then you have chirps, which are an average across the spectrum. You also have chirps that are frequency specific. So you could have low, mid, or high frequency chirps. Chirps are used more now because they elicit a higher wave 5 response. So clicks are better for wave morphology. If you're looking for all the waves, clicks will give you all the waves. If you're looking for a bigger response or quicker response, then chirps will give you a bigger response. It doesn't mean that any protocol is right or wrong. It just means that there's different applications of the protocol. Okay? Frequency of the stimulus. So as we know, the cochlea has different places for different frequencies. If you use a higher frequency, you will get a quick response because it's right at the basal turn of the cochlea. If you use a low frequency, you will get a slower response, and that's because that sound has to travel all the way up to the apex, and then you'll get your response. Okay? And the intensity. So as the intensity goes low, the response will also decrease, and it will be a bit later. So these are just examples of different stimuli and different responses. This is a high frequency tone burst, so you can see that you have your wave 5 at around 6 milliseconds, and then this is a low frequency tone burst where you have your wave 5 at around 11.5. So you can see there's a big difference between the high frequency and the low frequency. It doesn't mean that anything is wrong. It just means that the low frequencies take a bit longer to show you a response than this is the broadband chirp. So this is what we commonly use, the chirp response. Again, I can see wave 3, I can see wave 5 within time. So, and then you have the click, and the click will show you all the waves nicely. So you can see in the tone bursts, you can see some of the waves. In the chirps, you can see some of the waves, but the clicks will show you the most prominent and the most easily identifiable waveform. Different clinics, different patients, different protocols, and different equipment have different protocols as well. So none of these are wrong. It depends on whatever application you're using it for. If I want to investigate a sloping hearing loss, I might go for the bursts because I want to see how it performs at 500 Hertz, low frequencies, and then at higher frequencies as well. If I'm just doing a normal threshold test, like a kid comes in and we're doing their first threshold examination, 2 to 3 year old kid, I'll use chirps, especially if we're making them sleep. We don't know how long they will sleep for. You need something that's quick. And in our clinics, sometimes also you might have other noise, artifacts, things like that, so you use the chirps because it's quicker and it's more robust. I'll also use clicks sometimes, but clicks now these days I use them only for cases where I want to investigate the functioning of these wave centers. So clicks, most of the times now I'll use them in cases of neurological deficits. So if I want to investigate whether there's some neuropathy going on, not auditory neuropathy alone, but if there's some, maybe some, like patients with MS, patients with other neurological issues, you might use your click to show you all those centers whether they're functioning correctly. Not something that we do very frequently, but I've done it in the past. Okay? There are some other stimulus related factors which we will see in the when we demonstrate. The stimulus rate is important. So how many runs are you presenting per cycle? Okay? A higher rate will give you a faster test and a faster response, but it might not give you the most clear response. Okay? So if you go faster, yes, you might get a quicker response, but you might not get a very clear response. Polarity is the other thing, so you can change the polarity of the stimulus to check different runs, and you can, because what happens normally is you use an alternating stimulus, and you can change the polarity from a rarefacting to condensating stimulus, and that just changes the phase of the stimulus. So you can look at the cochlear function or the auditory brainstem function along those different polarities. It's useful investigating things like ANSD, because that's how you measure whether there's any cochlear microphonic that gives you evidence of ANSD. And the transducers. Inserts are better. So when you use inserts, you might get a better response than when you use headphones. And that's because of how it sits on the ear, how it opens up the ear and sends the sound directly towards the tympanic membrane. Now, when we look at recording factors, we look at electrode placement. So electrode placement is very important. The electrodes need to be in the right places, and they need to be placed properly, and you need to make sure that they're contacting the skin the entire time the test is going. Sometimes we will do a test and you're busy with the machine or the laptop or something, and you've got a response and you're testing, and all of a sudden you see that the waves are not coming, there's no response. That doesn't mean that there is no response. Sometimes the electrode just comes off, especially if you're using the sticker electrodes, or even if you're using the other ones. Sometimes it'll just come off. Okay, it happens. It's happened many times. It happens that, and you just have to check. Just put it back, and the test should continue as normal. Okay. Now you could use a mastoid placement. You could put it on their earlobes. There's different placements for the electrodes. It depends on, again, what protocol, what equipment you're used to, and what you're looking for as well. I prefer to use mastoid. So I prefer to put the, we'll see this later, but the high forehead positive and then the negative on the mastoid itself, behind the ear. The other thing that you need to look at is how many sums you're doing for the stimulus, so how many runs you're looking at. Typically around 1,000 to 2,000 is okay. Again, the machine does this for you, so you can just set it on the machine and let it run. And you can do this manually also. You can stop the run when you think you have enough responses. Okay? Now, this is something that we would call a perfect recording. So there is no noise. There's someone there. Okay, so this is something we would call a perfect recording. There is no noise. You can see all 7 peaks. On the left side, you can see 5 peaks. That means that the recording conditions were perfect, the patient conditions were perfect, the electrode placement was perfect. Everything is clean. Okay? In clinic, or when you're doing this on patients, 90% of the time you cannot get a recording like this. There's noise, the patient is moving, there's recording conditions. Sometimes the electrodes are placed a little bit out of place. Sometimes you haven't scrubbed the skin properly, which is all normal, but it just means that you will not get a recording like that most of the time. Now, when it comes to patient preparation, we always schedule ABRs in the morning. So we always do them in the first half of the day. One is ready? Okay. So should we pause here and then see the patient and then come back? Okay. All right, cool. Okay. So you ask them to wake the child up early, bring the child to the clinic in the morning, and then make them sleep. You need some history to be taken, so you need to know what the complaints are, what the patient history is, what the parent or the family history is, if there are any infections in the past, any other neurological issues, what exactly is going, developmental issues, what exactly is going on with the child. Now, sometimes the child will, okay, and the birth and the antenatal history. The other thing is that you have to recommend the relative. If they're brought into the room while they're awake, generally they don't go to sleep because the room might be cold, they might see a lot of people around, so they don't. So it's better that they sleep outside, and then their evidences if they get in the way. Yeah. Left and right mastoids. I use a lot of oil or cream. You can use some of that paste to clean. Prep the skin better, you will get lower impedances. Skin properly, you might not get good recordings. And this is because ABR waveforms have a good contact and you can read these electric measurements through the skin. Demonstration, we have different colors that stand for different things. So we have the red, which is the forehead, then we have the green, which is the common electrode, and then we have the mastoids. Okay, so we have the black ones, channel 1, which is the right one, and channel 2, which is the left one. And then in the red slots, we put a jumper cable that takes the signal from one to the other. And that's just because we don't want to use 2 positives, we use 1 positive. Okay? To begin the test, you ensure that the electrodes are placed properly, and you use either inserts or headphones. So make sure you make them wear it, and you enter the patient details. Make sure you have the patient details as well. we should not be looking for these details while we're doing the test, but there are cases where you can do the test and then you can enter the details later. It depends on the situation, of course. Stimulus parameters, as we saw, you have to apply the correction factor for click 11.1. Now, this is all dependent on the equipment you use and what you're doing with it, or what stimulus you're using. So in that one, for the specific setting that we're using, we apply that correction factor. Okay? So this is what I'm showing you. You go into stimulus, then you apply this correction factor. Click 11.1 and you click done. Okay? Now this is the test view. So as we saw, this can show you your impedances. There's a button to start. You can change the scale up there. You can change the side and the transducer and the intensity over here, and the stimulus rate or stimulus runs here. Okay? Patient details should be entered, and it's month, date, and then year. We'll give you the presentation so you'll have access to them. When you run the test, you test one side at a time on the system, so we don't do a bilateral recording. You can begin at 60 or 70 dB. Now, it will depend on what protocol you want to use. So, some places will 70 dB and they will go down by 20, down by 20, and then up by 10, down by 20. We normally go down by 10 and up by 10. If we get a response at 70, I'll go to 60, then 50, then 40, then 30. If you don't get a response, you go up the other way. So at 70, we did it twice, we didn't see a response, go up to 80, up to 90. Okay? Don't see responses 2 or 3 times at 90, you know it's a profound hearing loss. Or the setup is wrong, or the equipment is not working. But, yeah. And if you see a clear response, you can stop the test. You don't have to wait the 2 minutes while the runs finish, the 2000 runs. If you see a clear wave 5, if you see a clear response, if the waveform looks stable, then you can stop the test and start another run. You need to save time. Yep, so you decrease by 10, increase by 10, and try to gather as much information as possible, because you're trying to do this test before the child wakes up. So, like side, but we've still tried to do one side. You know, if you do it 6, 7 times, increase the amount of runs that you can do and the amount of information that you can gather. Okay?
So normally runs takes 2 minutes.
About 1 minute to 2 minutes, depends. Yeah. The reason, so this is with this back, because of how quick and efficient this is. Kwenye gari unafanya kwenye gari. Yeah, we've done it. I've done it in the parking lot. I've done it in theater. I've done it so many places at 2, and normally we'll use either 5 or 2. Okay? You can see there's a definite response. So make sure you check at different scales. Okay? Be an issue. APD, central auditory processing disorder, is still a thing. There could be there's something else that's going on. Okay? The other thing is that you should gold standard. It's not the gold standard. Okay? It's not all we can do. We can do many other tests that can tell us many other things into account when you're doing the final diagnosis of the patient and the management of the patient, and which is something that we have seen. Okay? Now, if in at 90, are there peaks at 80? You tested 1 year, you couldn't chemo, and then you can give your diagnosis. There are some every week until I have the results, until I'm confident with the results. Just because you have seen one thing that might be a peak diagnosis, we don't. We have to make sure that we know what we're giving the child a hearing aid when he doesn't need a hearing aid, or giving the child a normal clear wave 5. That will show us whether there's a response at 70 dB, 60 dB, 2 or 3. And does it correlate with other tests or negative ABR that shows a hearing loss, but it might be the equipment that has failed. And it has happened. Want and what information you want and what. Or if there's a hearing loss, they will do a bone conduction, then they will do tone burst, tone burst, tone burst. Okay? It's the time that we spend and get the most information out of it as well. Okay? And the protocol that you use to threshold as well. So do you consider normal? Some clinics, they will take normal hearing as 20 dB on ABR. ABR that I saw it was reported as normal, 6, and then this side it's at 3 and 5. There's no morphology, you cannot see that waveform. So this patient was discharged as and it's a profound hearing loss. Okay? So these are the things to keep in mind. If you're not sure, ask. If you're still not sure, repeat that. On that first patient, you know, we marked a few peaks and then we removed them. Yeah. And it's the same.
Always on marking, you always take the latency. Oh, what makes...
Right? But the amplitude is not there. When we look at this, again, it's the same. You can see some, so we'll take a look later on. The other thing that we can talk about is the bone and I have a bone conductor so we don't have one for the Labat machine, but we have, you know, yes, maybe they don't have ears, external ears. You still need these. So with wax, sometimes if you do the normal ABR, it should still give you results. You can do it. It's not a must to always clean though. It's slightly delayed waves. You might get a conductive hearing loss. Do it, yes, you can do it, and the results can still give you some information.
But with the new machine,
you can do bone conduction and air conduction, yes.
Yeah, okay.
Yeah. But the bone conduction has, so the bone conduction does have a limit in terms of the intensity. So you can only go up to about 50 or 60 dB, which means that at about 50 or 60 dB, you will get a negative response. It means that you're still not sure if the child is hearing up to 90, from 50 to 90. You
get the machine down.
Well, for the
ear, and then you do the...
and the OEs are present. So the results are not correlating because the nerve itself is the one with the dysfunction. Okay? The second case, as we discussed, was the asymmetrical hearing loss. So the difference between the two sides. On the right side, we can see wave 5 is present up to 90 dB. On the left side, it's not there. Okay? So there is a difference between the two. And you confirm that there's no other reasons. There's no atresia, there's no middle ear fluid. You can do the tympanometry to find out. You can check that there's no other issues. So then you know that it's a problem. There's a profound hearing loss here, severe hearing loss there. Okay? The third case is a functional hearing loss. So again, like I said, in occupational cases, this was a case where the PTA was showing a severe to profound hearing loss in an adult after an accident at work. And we did the OEs, and OEs were present. We did the ABR, and the ABR is completely perfect. So up to 30 dB, all the peaks are present. We just...
Then you need a bodyguard.
No, we prepare the report and we send it to the...
That's why I'm saying, next time you come with a gun.
Yeah, you have to be...
For them to be fair, this, the client to different clinics.
No, so they go to a few different clinics.
So that they don't know.
Yeah, so we see a lot of these. We used to see a lot more. Yeah.
Very challenging.
So yeah, this is the. We also see this one in the household who has a hearing loss. And they're very clever. They'll imitate them almost perfectly. They act like they have a hearing loss. They stop talking suddenly. The parents are actually concerned. And for us, you know, if sudden hearing loss in anyone is, then you do the ABR and you find out it's normal. and then you refer the child to psych. The other case is a conductive hearing loss. So there are two ways of detecting. This is a conductive hearing loss. So bone conduction 20 dB, air conduction 40 dB. Now ABR, we're getting here up to 65 dB. You can even say a little bit up to 50 is maybe, but 65 dB. But the peaks are very delayed. So they should be here, but they're actually here, okay? And that's a sign of a conductive hearing loss. So even on air conduction ABR, if you have a bit of wax, a little bit of fluid, otitis media or something, you can estimate the conductive hearing loss by using this principle. This is a case of moderate to profound hearing loss. ABR is showing peaks at 70, which is suggestive of severe hearing loss. When you're fitting the hearing aid, you can use this as a baseline, but always remember that for hearing aid fitting, PTA is better. So whenever you can do it, even at the 6-month follow-up, 12-month follow-up, do the PTA. And this is what we found on the PTA. So it shows up to 70 dB in this region here on the ABR, but this is the PTA. So we fine-tune the hearing aid according to the PTA then.
And how old was the patient?
I think the patient was about 4. Yeah, 4 at initial, and then the PTA we probably did at like 5 or something. Yeah.
So that is moderate.
Yeah, this is more.
Because we have had recently a case like that. The ABR was profound. Now this time the repeat PTA, it was good. Ile mtoto alifanywa ABR kwa kuonyesha ABR inaonyesha PTA inaonyesha hivi. Kwa sababu PTA is always better.
As long as it's reliable, so some, yeah.
Mtoto anaweza
Then the ABR will be abnormal, even if the PTA is normal. So if you get those sort of confusing results and the child has a concern, the main thing is the concern. Kama mtoto anaendelea vizuri, it doesn't matter whether your ABR is abnormal. Right. If you're not hearing properly, speech and language is not developed, it's a concern that they have and what you're looking for then. Yeah. So you, again, if the ABR, if you get those sort of confusing results, the stimulus wasn't right, maybe the electrodes weren't placed correctly, maybe there were some issues with the recording, so you report. This is a patient that we had with microtia in the left ear and anotia on the right ear. Okay, we did the test with air conduction. We found delayed peaks up to 80, and we could put the headphones over it, but this is what we left side. On the right side, there was no ear. There was nothing here at all. So what we did was the bone conduction, and this is the bone conduction ABR. So 50, 40, 30, and 20. We can see good responses. The management for this then is that we use a bone conduction hearing aid. So we fitted the child with a bone conduction hearing aid and they're doing fine. Okay? And then we send them also for CT scans and for reevaluation at 6 months. Tomorrow I have a presentation on how to manage conductive hearing loss and non-surgically. So we will take a look at how to manage conductive hearing loss. So the ABR is so make sure that the setup is good and the interpretation is good. So the same thing like in any other medical application, if your treatment will be incorrect. You don't want to do an ABR and you're not sure what it tells you. It's a tool that we can use for the final diagnosis, but it is not the final diagnosis. Sometimes if you see a profound hearing loss on ABR, you can still be confused. Tests into account, you have to take your management plan into account. You have to take all of these things into account before you use it as a tool for the final diagnosis. Okay? And then the last thing that we have, the other EP test, is ASSR, which is another measurement of the auditory pathway. Now this interpretation is even objective. So you make them wear it, and it runs the test entirely on its own, and it estimates audiograms. So it will give you an estimated audiogram at 4 frequencies. Okay, and then you can use this audiogram for hearing aid fittings. You can do this with the same electrode setup as the ABR. We don't do it. Okay, I'm not sure. Of course, experiences vary, but sometimes it's more time consuming. It does take more time to do. If you have an ABR, let's say you've done an ABR and it's showing a moderate hearing loss in a 1-year-old or a 2-year-old, you can't do PTA. You want to find out whether the hearing loss is sloping, you have the option to do an an ASSR, or what I prefer to use is to use tone burst ABR to estimate the threshold. So you have different tools available. It's not that one test and one protocol is the one that you should do. You use different things to find different information that you can then use for the patient. Okay?
But it's the same machine?
Same machine.
You just say now...
The Labatt one has it. All of them have it. Yeah.
Just set.
Yeah, you just... Yeah. So this one, like the one, I don't keep the ASSR module on this one. So it's more expensive, but there's like the return isn't that much. You won't use it as much as, so it's not worth it.
You have to upgrade it, right?
Yes, exactly. So even in the one that you have, the ASSR is not standard. You have to upgrade it. Now the good thing is when we got these machines, we got them to give us, I think, a discount or something on the upgrade. So we got them with ASSR. I think this one has it as well, but we don't use it, to be honest. So.
Yupi, the down one. Wajua chini. Let's go.
Okay.
Wajua iswa chini wajua. Ngoja kwa. Where is the patient? Let's go up.
Let's go here. Okay. So we're done. Tumemaliza.